Assalamualaikum dear candidates. I am Dr. Nadia, gynecologist, and today we will discuss about the ovarian cancer. Now, first of all, the thing is the signs symptoms of the ovarian cancer. So, as all of you know, that ovary is basically an adnexal tissue which is meant to produce the follicles, where at every menstruation the follicles are matured and they are egg is released, and in this way the capsule is ruptured. So once there is some pathology, ultimately some mass can be there, and whenever a mass, definitely you know that ultimately either it can produce some pressure symptoms anteriorly or posteriorly or in the pelvis. So anteriorly, if it produces symptoms, it will lead to frequent micturition, or it can lead to abdominal bloating, because it pressure exerts the pressure on the stomach, and also feeling of fullness will be there, and patient may experience pelvic pain. And similarly, if there is advanced stage disease, then in that case there can be involvement of the gut, so there can be changes in the bowel habits, and there can be fluid collection because of the rupture of the capsule of ovary, and also there can be pain with intercourse. Now, as far as the ovarian cancer types are concerned, so you must remember that there are different types. Either there is epithelial tumor or non-epithelial tumor. So epithelial are basically three types. These are serous, endometrioid, and four types: serous, mucinous, endometrioid, and clear cells. So they can further be categorized into high grade and low grade. And I have discussed with you that which type of mutation is associated with these type of the tumors. And also the non-epithelial tumors are the germ cells, ovarian sarcoma, sex cord stromal tumors, and the sex small cell carcinomas. So, depending upon the type, they can either arise from the ovarian surface or they can arise from the ovarian stroma. So, you know, all of you know that ovarian stroma, it basically it can produce it's producing the germ cells, and these ultimately the tumors are associated with germ cell carcinoma. And their age incidence also varies according to the presentation of the tumor. So we will learn that at which age which of the tumor is more common. Now we have talked about different types of the tumors. First, we've discussed that these can be epithelial or non-epithelial. If we talk about the epithelial, so mainly these are serous. As far as they are about 70% in cases, there are serous carcinomas. They can be either low grade or they can be high grade. And also the endometrioid, basically they are mostly in 2 to 10% of the cases, and they can arise from endometriosis. And mucinous are also very much less in the incidence, and this mucinous tumor can coexist in appendix because the lining is same. So you have to rule it out that either it is metastatic or it is primarily from the ovary. And then clear cell carcinoma is basically, you must remember that what is the type of lining of the tumor, and accordingly you have to sort out that either it is from some other cell being metastasized to the ovary, or it is primarily from the ovary. And ultimately, depending upon this, we have to determine the histology. That normally the ovarian surface is actually the serous lining. So mainly in 70% of the cases, the serous ovarian tumors are there, which mostly occur in extreme of age, that is more than 60 years. And the one thing is that why ovarian cancer is being diagnosed very late. So this is because first is that we usually omit the pelvic examination at the first visit. And also the patient is actually when the patient is presenting to us, mostly she is bloating or she has pelvic pain or abdominal distension. So we take it as either as irritable bowel syndrome, or we take it as gastritis. So usually we avoid the test like tumor markers or ultrasonography or CT scan. We give the symptomatic therapy to the patient. So these are actually causing the progression of the disease, and so ultimately the patient usually presents to us with late stage, and that stage is actually when there is rupture of the capsule of the ovarian tumor. and this rupture of the capsule in turn leads to pelvic ascites, and this ultimately leads to abdominal distension and also the pelvic pain, and this may lead to peritonitis as well. So usually when the patient presents to us with the symptoms like she is having increased micturition, bloating, and or abdominal distension, continuous backache, we have to sort out the patient very clearly. Now you must remember the tumor markers associated with the ovarian tumors. That alpha fetoprotein is actually a germ cell tumor. That in that case the yolks the alpha fetoprotein is actually a tumor marker, and this is increased in case of yolk sac tumor or immature teratoma or embryonal carcinoma or satellite Leydig cell tumor. Beta HCG, you know all very well that choriocarcinoma leads to increased levels production of beta HCG, also in case of dysgerminoma or embryonal carcinoma. LDH is specifically is raised in case of dysgerminoma. This is a very aggressive tumor, and also you know that CA125 is characteristically raised in epithelial tumors, and inhibin and also estrogen both, they are raised in the granulosa cell tumor. So actually these tumor markers are specific according to the tumor, and some tumors they present in the young age and some tumors they present in the old age. So you should know that the germ cell tumors, they are primarily the tumors of the young age, and the serous tumor is primarily the tumor of the old age. So according to the presenting complaints of the patient, you will advise the tumor markers, and according to the and further we proceed for the investigations. Now, how is ovarian cancer diagnosed? So, as I have told you before, the tumor markers are primarily most important, and you must know that at which age which of the tumor is most common. And also ultrasonography is to rule out. And regarding ultrasonography, transvaginal scan has got an increased sensitivity to pick up that which tumor is most likely, that its adnexal mass, its how much size and its vascularity and all, you have to detect it. And further, if you are suspicious that there is some tumor, then definitely you have to go for the pelvic CT scan. And on this pelvic CT scan, definitely if you are suspecting some tumor, ultimately you have to state that either there is how much is the extent of the tumor, is there any nodal metastasis or any rupture of the capsule leading to pelvic ascites, or either it is primarily the ovarian tumor or it is the metastatic tumor arising from some other area involving the ovary. So ultimately, based upon the diagnosis, ultimately you will define the treatment or management strategy of the ovarian cancer. Like in early stage disease, you can manage it by surgery, and in the late stage, definitely you have to go for the palliative cure. So now FIGO staging, you must remember that in FIGO staging, the stage they are characteristically divided into 4 stages. In stage 1, actually it's first it discusses that one ovary is involved, then both ovaries are involved, and then the capsule is ruptured. So first the capsule is ruptured, and then ultimately it will lead to a pelvic ascites. So these all are the features seen in the stage 1. And then in stage 2, actually what happens that there is pelvic extension, and then in stage 3, characteristically you must remember that there is lymph nodal involvement. And all of you, as you know, that in case of stage 4, actually there is distant metastasis. So this distant metastasis can involve ultimately the later spread. It can lead to extra abdominal organs spread. It can lead to inguinal lymph nodes involvement. So we have to know that how is the mode of spread of this malignancy. And actually in stage, you must remember that in stage 1C, there is rupture of the ovarian capsule, and this in turn leads to spillage of the ovarian fluid into the pelvic cavity. And now furthermore, how is the management of the ovarian cancer? So definitely you must remember that if the patient is presented to you with early stage disease, then in that stage definitely you have to go for the optimal debulking surgery, that is called a cytoreductive surgery, or primarily it's called optimal debulking surgery, in a way that the residual tissue should be not more than 0.5 to 1 centimeters. You have to remove the disease maximum. So ultimately you have to go for the surgical management. And also, if the patient is presented to you with advanced stage, definitely you cannot go for the a total removal of the disease. It's actually a multidisciplinary team approach, and you have to define that either first, because if it is causing the abdominal distension, or it's causing distress to the patient, then you have to go for the debulking surgery, or you can go for cytoreductive surgery. And after that you will put the patient on chemotherapy. And you must remember that cisplatin, paclitaxel, these are the optimal chemotherapeutic agents which are being used in case of ovarian cancer. And then the follow-up schedule of follow-up is that usually it's every 3 to 4 months for the first 2 to 3 years, and then after finishing the first initial treatment, then after every 4 to 6 months for the next 3 years, then after that it's once a year. So you, according to the state of the disease, you have to decide the follow-up, and ultimately in every follow-up you have to assess the patient by vaginal examination, you have to go for tumor marker, and you have to go for the transvaginal scan to see that is there any recurrence of the disease or any spread of the disease to disease. So ultimately in this way you will define a follow-up visit for the patient. This was all about ovarian cancer, and regarding its types, its presentation, its diagnosis, and its management. And if we talk about the germ cell tumors, in that case the prognosis is very good, and the only management is that we go for the surgical management, in a way that we go for the oophorectomy in that case. Thank you.